All right, let's jump right in. Chest pain. It's got to be one of the scariest symptoms you can have, right? And for a doctor in a clinic, it's a huge puzzle. How do you sort through all the possible reasons to find the one that could actually be life-threatening?
So just how common is this? Well, believe it or not, about 1% of all visits to a primary care doctor are for chest pain. Now, 1% might not sound like a huge number, but when you think about it, that's millions and millions of appointments every year. It's a puzzle doctors are trying to solve every single day.
But here's the twist, and this is really important. Despite all that worry, when you're in a doctor's office, there's a 97% or even higher chance that your chest pain has absolutely nothing to do with a heart attack. So the real challenge the whole game is finding that dangerous 3% that's hiding in plain sight, and that's exactly what we're going to unpack.
So how do doctors do it? They use this great mental model that we're going to call the diagnostic funnel. First, we'll look at the big picture, the puzzle itself. Then we'll zero in on the top 3 scariest possibilities. After that, we'll talk about the very first, most critical test they run, how they score your actual risk, and then we'll get into what's usually causing the pain. And finally, we'll tie it all together to see the whole system in action.
Okay, so why is a system like this so incredibly important? Well, it's because cardiac pain, it's a real master of disguise. That classic, crushing chest pain you see in movies, it doesn't always happen that way. Especially for women, older folks, or people with diabetes, it can show up as something totally different, like just feeling weak or nauseous or even just short of breath. So you see, you just can't go by the textbook symptoms alone.
And that brings us right to the top of our funnel, where the stakes are as high as they get. The absolute first priority before anything else is to think about and rule out the 3 big killers. Acute coronary syndrome, that includes heart attacks, aortic dissection, which is a tear in your body's main artery, and a pulmonary embolism, a clot in your lungs.
What's interesting is that the textbook descriptions for these are all pretty different. For acute coronary syndrome, it's that classic pressure. An aortic dissection is often described as a sudden tearing pain. And a pulmonary embolism, that's usually sharp and hurts more when you take a deep breath. These are the first clues, but, and this is a big but, patients don't always read the textbook. And that's why we have to move beyond just what someone says it feels like and get to the objective tests.
Right, so the moment a serious heart problem is even a possibility, a clock starts ticking. There is one test that is absolutely critical, has to be done, and it has to happen fast.
So what do you think it is? What's the one test that needs to be done within 10 minutes? The answer to this really sets the course for everything that follows and can, quite literally, be the difference between life and death.
And the answer is the electrocardiogram, or ECG. It's that quick, painless test that reads the electrical signals of your heart. Its number one job, its most critical role, is to spot a very specific, very big type of heart attack called a STEMI. And believe me, finding a STEMI on an ECG is like a 5-alarm fire bell going off. It triggers an immediate emergency response. So when doctors look at that ECG printout, they're not just looking at squiggly lines. They're scanning for very specific patterns. That ST elevation, that's the fire alarm I was talking about. It screams STEMI. But other, more subtle changes, like ST depression or new T-wave inversions, those are also major red flags that the heart muscle just isn't getting the oxygen it needs. Okay, so let's say the ECG doesn't give a clear-cut answer. What happens then? Well, we move down to the next layer in our funnel, figuring out the actual risk level. And instead of just going on a hunch, doctors use these proven scoring systems to calculate the real probability of a heart problem. A great example is the Marburg Heart Score. It's actually surprisingly simple. You get 1 point for each of 5 things: your age and sex, if you already have known vascular disease, if the pain gets worse with exercise, if you can't make the pain worse by pressing on the chest, and finally, if you yourself think the pain is coming from your heart. It's pretty straightforward. If you score 3 or more, a cardiac cause starts looking a lot more likely. And here's another really powerful tool, the inter-chest rule. It works in a similar way, adding points for risk factors, like your age, or if you have a history of coronary artery disease. But where this one really shines is at the low end. If your score is less than 2, there's only about a 2% chance you have a significant blockage. Think about that. That's an incredibly powerful way to confidently rule out a heart issue and give a patient some much-needed peace of mind. So after our funnel helps us rule out all those scary, life-threatening heart conditions, what's left? We're left with that other 97%, the stuff that's way, way more common. And when you look at the breakdown, it's pretty eye-opening. A full 50%, half the time, chest pain in a primary care setting is musculoskeletal. It's literally pain coming from the muscles and bones of the chest wall itself. After that, you've got acid reflux, or GERD, then costochondritis, which is just inflammation where your ribs meet your breastbone, and even things like panic attacks. The heart, it's actually pretty far down the list of what's most likely.
And each of these common causes has its own telltale signs. For instance, if a doctor can press on a specific spot on your chest and you say, "Yep, that's the pain," that points right to a musculoskeletal issue. A burning feeling moving up from your stomach, maybe a sour taste, that's screaming acid reflux. A sudden wave of intense fear with a pounding heart, that could very well be a panic attack. Each one has its own signature. And this really brings us to the big takeaway. This whole process, this diagnostic funnel, is what lets a doctor take a symptom that is, frankly, terrifying and work through it in a safe, logical way. It's all about creating order out of what could be chaos. So let's just quickly walk through that journey again. It all starts with triage, right? Making sure the patient is stable. Then you immediately focus on ruling out the worst-case scenarios, the big three. Next, you get that critical ECG done within 10 minutes. After that, you use those objective scoring systems to figure out the risk. And only then, once you've established it's not an emergency, do you start looking to all those other, more common causes. You know, in the end, it all boils down to this one guiding principle from the American Academy of Family Physicians. You always have to assume it could be the heart and prove that it's not. It's a safety-first mindset that makes sure that tiny chance of a catastrophe is never missed. You know, this whole approach, starting broad, ruling out the absolute worst possibilities first, and then systematically narrowing things down, it isn't just for medicine, is it? It's a really powerful way to tackle any kind of complicated problem. It makes you think, what other chaotic problems in our own lives could use a good diagnostic funnel?